Hi, today we will be discussing Chapter 179 of Harrison's Principles of Internal Medicine. This chapter deals with leptospirosis. This slide presents the outline on how this topic will be discussed. Leptospira species are spirochetes belonging to the order Spirochetalis and the family Leptospiraceae. Traditionally, the genus Leptospira is comprised of two species, the pathogenic L. interrogans and the free-living L. biflexa, now designated as L. interrogans sensulato and L. biflexa sensulato respectively. 22 Leptospira species with 10 pathogenic species, 5 intermediate species, and 7 non-pathogenic species status have now been described on the basis of phylogenetic and virulence analysis. Leptospiras are coiled, thin, highly motile organisms that have hooked ends and two periplasmic flagella with polar extrusions from the cytoplasmic membrane that are responsible for motility. They stain poorly but can be seen microscopically by dark field examination and after silver impregnation staining of tissues. Leptospiras require special media and conditions for growth. It may take weeks to months for cultures to become positive. Leptospirosis has a worldwide distribution but occurs most commonly in the tropics and subtropics because the climate and occasionally poor hygienic conditions favor the pathogen's survival and distribution. Most cases occur in men, with a peak incidence during the summer and fall in both the northern and southern hemispheres, and during the rainy season in the tropics. Current information indicates that approximately 1 million severe cases occur per year, with a mean case fatality rate of nearly 10%. As a zoonosis, leptospirosis affects almost all mammalian species and a significant veterinary burden. Rodents, especially rats, are the most important reservoir, although other wild animals, as well as domestic and farm animals, may also harbor these microorganisms. Transmission of leptospiras may follow direct contact with urine, blood, or tissue from an infected animal, or more commonly, exposure to environmental contamination. Because leptospiras can survive in a humid environment for many months, water is an important vehicle in their transmission. Certain occupational groups are at especially high risk, including veterinarians, agricultural workers, sewage workers, slaughterhouse employees, and workers in the fishing industry. Risk factors include direct or indirect contact with animals, including exposure to water and soil contaminated with animal urine. Recreational exposure and domestic animal contact are prominent sources of leptospirosis. Recreational freshwater activities such as canoeing, windsurfing, swimming, and water skiing place persons at risk for infection. In addition, leptospirosis is a traveler's disease. Large proportions of patients acquire the infection while traveling in tropical countries, usually during adventurous activities such as whitewater rafting, jungle trekking, and caving. Transmission occurs through cuts, abraded skin, or mucous membranes, especially the conjunctival and oral mucosa. During the leptospiremic phase, the bacteria enters the host and then proliferate and cross tissue barriers, allowing hematogenous spread. During this phase, the leptospiras may be isolated in the bloodstream. During the immune phase, the appearance of antibodies coincides with the disappearance of leptospiras from the blood. However, the bacteria persist in various organs, including liver, lung, kidney, heart, and brain. Renal pathology shows both acute tubular damage and interstitial nephritis. Acute tubular lesions progress in time to interstitial edema and acute tubular necrosis. Severe nephritis is observed in patients who survive long enough to develop it and seems to be a secondary response to acute epithelial damage manifesting as impaired sodium absorption, tubular potassium wasting, and polyuria. Histopathology of the liver shows focal necrosis, but widespread hepatocellular necrosis is usually not found, foci of inflammation, and plugging of bile canaliculi. Petechiae and hemorrhages are observed in the heart, lungs, kidneys and adrenals, pancreas, liver, gastrointestinal tract, muscles, prostate, testis, and brain. Several studies show an association between hemorrhage and thrombocytopenia, although the underlying mechanisms of thrombocytopenia have not been elucidated. It seems likely that platelet consumption plays an important role. A consumptive coagulopathy may also occur. Although leptospirosis is a potentially fatal disease with bleeding and multi-organ failure as its clinical hallmarks, the majority of cases are thought to be relatively mild, presenting as sudden onset of a febrile illness. The incubation period is usually 1 to 2 weeks but ranges from 1 to 30 days. Leptospirosis is classically described as biphasic. The acute leptospiremic phase is characterized by fever of 3 to 10 days duration, during which time the organism can be cultured from blood and detected by polymerase chain reaction or PCR. During the immune phase, resolution of symptoms may coincide with the appearance of antibodies, and leptospires can be cultured in the urine. In mild leptospirosis, most patients are asymptomatic or only mildly ill and do not seek medical attention. It presents as a flu-like illness of sudden onset, with fever, chills, headache, nausea, vomiting, abdominal pain, conjunctival suffusion, and myalgia. Muscle pain is intense and especially affects the calves, back, and abdomen. The headache is intense, localized to the frontal or retroorbital region, and sometimes accompanied by photophobia. Physical examination may include any of the following findings, none of which is pathognomonic for leptospirosis. The natural course of mild leptospirosis usually involves spontaneous resolution within 7 to 10 days. Severe leptospirosis is often rapidly progressive and is associated with a case fatality rate ranging from 1 to 50%. Higher mortality rates are associated with an age over 40, altered mental status, acute renal failure, respiratory insufficiency, hypotension, and arrhythmias. The classic presentation, often referred to as Wales syndrome, encompasses the triad of hemorrhage, jaundice, and acute kidney injury. Patients die of septic shock with multi-organ failure and/or severe bleeding complications that most commonly involve the lungs manifesting as pulmonary hemorrhage, bleeding in the gastrointestinal tract manifesting as melena, hematemesis, hematochezia, bleeding in the urogenital tract seen as hematuria, and bleeding in the skin seen as petechiae, ecchymosis, and bleeding from venipuncture sites. Jaundice occurs in 5 to 10% of all patients with leptospirosis. It can be profound and give an orange cast to the skin, but usually is not associated with fulminant hepatic necrosis. Physical examination may reveal an enlarged and tender liver. Acute kidney injury is common in severe disease and can be either non-oliguric or oliguric. Typical electrolyte abnormalities include hypokalemia and hyponatremia. Loss of magnesium in the urine is uniquely associated with leptospiral nephropathy. Hypotension is associated with acute tubular necrosis, oliguria or anuria, requiring fluid resuscitation and sometimes vasopressor therapy. Hemodialysis can be life-saving, with renal function typically returning to normal in survivors. In severe leptospirosis, altered mental status may reflect leptospiral meningitis. Without proper antibiotic treatment, a mortality rate of 13% has been reported. In contrast, among patients treated with antibiotics, the mortality rate is 2%. Neurologic sequelae are described until months after acute illness. Other syndromes associated with leptospirosis are as follows. Long-term symptoms following severe leptospirosis include fatigue, myalgia, malaise, and headache and may persist for years. Autoimmune-associated uveitis, a potentially chronic condition, is a recognized sequela of leptospirosis. The clinical diagnosis of leptospirosis should be based on an appropriate exposure history combined with any of the protean manifestations of the disease. Although biochemical, hematologic, and urinalysis findings in acute leptospirosis are nonspecific, certain patterns may suggest the diagnosis. Laboratory results usually show signs of a bacterial infection, including leukocytosis with a left shift and elevated markers of inflammation, C-reactive protein level, procalcitonin level, and ESR. Thrombocytopenia, defined as a platelet count of less than 100,000, is common and is associated with bleeding and renal failure. The kidneys are invariably involved in leptospirosis. Related findings range from urinary sediment changes and mild proteinuria in mild disease to renal failure and azotemia in severe leptospirosis. Non-oliguric hypokalemic renal insufficiency is characteristic of early leptospirosis. In liver involvement, serum bilirubin levels may be high, whereas rises in aminotransferase and alkaline phosphatase levels are usually moderate. Although clinical symptoms of pancreatitis are not a common finding, amylase levels are often elevated. When symptoms of meningitis develop, examination of the CSF shows pleocytosis that can range from a few cells to more than 1,000 cells, with a predominance of lymphocytes. Although protein and glucose levels in CSF are usually normal, protein levels may be slightly elevated. In severe leptospirosis, pulmonary radiographic abnormalities are more common than would be expected on the basis of physical examination. The most common radiographic finding is a patchy bilateral alveolar pattern that corresponds to scattered alveolar hemorrhage. Other findings include pleural base densities, representing areas of hemorrhage, and diffuse ground glass attenuation, typical of acute respiratory distress syndrome. A definitive diagnosis of leptospirosis is based on isolation of the organism from the patient, on a positive PCR result, or on seroconversion or a rise in antibody titer. In cases with strong clinical evidence of infection, a single antibody titer of 1:200 to 1:800 in the microscopic agglutination test is required. Preferably, a fourfold or greater rise in titer is detected between acute and convalescent phase serum specimens. Antibodies generally do not reach detectable levels until the second week of illness. MAT and ELISA are standard serologic tests for leptospirosis, but because serologic testing lacks sensitivity in the early acute phase of the disease, it cannot be used as the basis for a timely decision about whether to start treatment. PCR methodologies, notably real-time PCR, have become increasingly widely implemented. Compared with serology, PCR offers a great advantage: the capacity to confirm the diagnosis of leptospirosis with a high degree of accuracy during the first 5 days of illness. This slide shows the differential diagnosis that may be confused with leptospirosis due to similarity in clinical presentation. They should also be considered and ruled out, most especially if with appropriate history and clinical setting. Severe leptospirosis should be treated with IV penicillin as soon as the diagnosis is considered. Other recommended antibiotics, depending on the severity of disease, are shown on this slide. For prevention, individuals who may be exposed to leptospira through their occupations or their involvement in recreational freshwater activities should be informed about the risks. The efficacy of chemoprophylaxis with doxycycline or azithromycin is being disputed, but focused pre- and post-exposure administration is indicated in instances of well-defined short-term exposure. Most patients with leptospirosis recover. However, post-leptospirosis symptoms, mainly of a depression-like nature, may occur and persist for years after the acute disease. Mortality rates are highest among patients who are elderly and those who have severe pulmonary hemorrhage or Wales syndrome. Leptospirosis during pregnancy is associated with high fetal mortality rates. Long-term follow-up of patients with renal failure and hepatic dysfunction has documented good recovery of renal and hepatic function. This ends the slide set on leptospirosis. Thank you.